morning, respected all. So, just want to highlight a few, topic and just put forward my preference of steroids in treating diabetic macular edema in most of the patients. So, Dr. Soumil said very elaborately, told how about forming a regimen. On the other hand, I will demystify saying that in a real world scenario, how patients come to me and how I go about dealing these patients. Let me put forth these four category of diabetic macular edema patients who present to me. The first one is a pseudophakic patient who has diabetic macular edema, or a patient who is going a concomitant cataract surgery and has a diabetic macular edema. The second would be a DME which is resistant to the anti-VEGFs. Third is a patient who is naive, who is phakic without the hyperreflective dots and with hyperreflective dots. And the fourth category is some special categories which I'll talk about. So if a patient comes to me with pseudophakia with diabetic macular edema, or a patient who has to have a cataract surgery who has diabetic macular edema, there is a class 1 evidence by protocol I which states that if you put steroids with prompt laser or ranibizumab with prompt laser or only ranibizumab, all fared the same. So it very well conclusively tells that if a patient is pseudophakic or if the patient has to undergo a cataract surgery with a diabetic macular edema, you can very well treat them with steroid, whether it's IVTA or a steroid implant. You're good to go in such patients. Coming to the second scenario, if a DME is there and a patient has already received anti-VEGFs at various other centers, but he has come to you, obviously it comes to you if a particular a physician has treated and the edema has not worked. So he comes to another physician, so he has landed up with you. So I can subcategorize into three situations where there was an adequate response to anti-VEGF, but it kept recurring, or he didn't have any inadequate response to the anti-VEGF which was given, or there was absolutely no response to the anti-VEGF. I'll just put off each of my patients into this category and show you. This first scenario is a 47-year-old gentleman who is a known diabetic for 12 years, moderate NPDR with CSME and CME. Multiple doses of anti-VEGF has been given. Let us not go into which anti-VEGF, but anyhow. So this is what it is. He has already undergone a peripheral photocoagulation just to, though he was not a PDR patient. The CME is still there. So investigation, we looked into all the investigations, whether any systemic profile were to, blame for this condition. Along with did the FFA and the scatter photocoagulation, which was already done. So we just gave one dose of Osidex in each eye, and this has been almost 28 to 30 months in both the eyes, and the edema didn't recur back. So if we just tilted the balance, we looked into all the various factors. Why did it have such a situation where had multiple recurrences, but a single dose of Osidex helped him out? But we couldn't really hit upon the target. But we do stumble upon such patients very often now and then. I think I already have 11 such patients in which over a period of time when we gave one Osidex or any steroid for that matter, even IVTA in some patient who couldn't afford dexamethasone implant, did respond like this without recurrence of diabetic macular edema. Second scenario, a 63-year-old gentleman, known diabetic, adequately controlled, documented DME, initiated on anti-VEGF. See, post anti-VEGF, there is some amount of response. But after an dexamethasone implant, see how beautifully the edema goes down. Completely normalization of the foveal contour. Coming to the third scenario, where 56-year-old lady presented with diminution of vision, known diabetic for 22 years. 3 anti-VEGF has been given, and the 4 in her left eye. At presentation, you can see that edema is still persisting. Post-Osidex, complete normalization of fovea at 1 month, at 3 months, and persisting at 5th month. That's what, as I told you, one of the patients, the recurrence of edema doesn't occur in these patients. We don't know what's the reason, but we do come upon such patients in our clinical scenarios. So coming to the third scenario, which I told, if a phakic patient comes to me who had hyperreflective dots, it's been well established that though the pathogenesis of HRD is a bit of controversial, but these patients do, the inflammatory biomarkers are much more higher in these patients in various, not only in diabetic, if it's in CRVO, RVOs or AMD, you give these patients with steroid implants, they do respond very well as compared to the anti-VEGF. The same thing which you can see over here, the patient has hyperreflective dots, which you can see in the outer retinal layers, and once the steroid implant has been given, the edema has responded, so has the HRD spots. This is another example for the same. So now comes to us a small category of patients who are naive, who are phakic. So we did a randomized trial at my center where we took 40 patients and treated them all with Osidex as the primary treatment to see what really happens in these patients. So minimum follow-up of 6 months we did include, and the longest in my kitty is about 24 months. The average CMT reduction in most of these patients, which come up to 182 microns, 11 patients required only one injection during the period of 6 months. So on added to that advantage, if the patient has hard exudates, it helps in resolution as compared to the anti-VEGF, though it's documented that even in anti-VEGF it responds, but Dex implant much better. You can see pre and post injection how wonderfully the hard exudates have responded. So the adverse effects to mention in these naive patients was raised IOP in 5 patients, which were very well controlled with one single medication, cataract progression in only 9 eyes. It's it's been associated with cataract patient. It's not that one Osidex injection will increase the cataract. It definitely not so. Endophthalmitis in a single patient, but no other major ocular events or like retinal detachment or vitreous hemorrhage or anything as such was noted. Just finished, sir. Special conditions like pregnancy and cardiac are the others in which you would prefer to give dexamethasone implant as compared to anti-VEGFs. Do all response to Osidex? I'll just show on one example. So at presentation, 1 week anti-VEGF, 1 month post anti-VEGF, nothing responded. Then again we gave an Osidex implant, didn't respond, but when we did some amount of focal laser, the patient responded to this. So incidence of resistance is less than 2 in around 868 applications that I have done at our center, much lower as compared to anti-VEGF.